Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. Certificates will be available on Monday by downloading those off your account. And towards the end of the webinar, we'll have a little bit of time to get through the questions that are submitted through the chat function, and I will be reading those to the presenters today. Jenny and Angela, if you'd like to get started, go right ahead.
Okay, thank you, Kim. And we welcome everyone today. Thank you for listening in. My name is Jenny Murray, and I am an IBCLC, and I have been a NICU nurse for about 20 years, or a little over 20 years, actually. And prior to joining Medela, I worked in the NICU as a bedside nurse and served in a variety of nursing and leadership roles during my tenure in the hospital. I joined Medela almost 6 years ago as a clinical NICU specialist. I am speaking to you today from the Dallas area, and I cover the central portion of the US in my current role. And I'm thrilled to be sharing this information with you alongside my colleague, Angela Groschner. Angela, who is also a NICU nurse and lactation consultant, has been in the field for more than 10 years, and she practiced in a level 4 NICU and has served in a multiple nursing leadership assignments. Angela joined Medela a year and a half ago and serves as a clinical NICU specialist covering the Northeast United States. So, really, what we hope you walk away with today is the understanding that human milk, or donor human milk, while often donated so very generously from moms, should never be looked at as an equal to mother's own milk. So, Angela and I are both employed full time by Medela, otherwise, we have no disclosures. And so our objectives today include differentiating between the benefits of mother's own milk and donor human milk and the impact on potentially preventable neonatal morbidities, as well as recognizing the economic benefits of prioritizing an exclusive diet of mother's own milk for improving neonatal outcomes. And then outlining support and education for clinicians as well as families to ensure the provision of mother's own milk and donor human milk. So, we'll talk about the value of human milk in both term and vulnerable infants, and we'll also discuss concerns around using donor human milk, the economic impact, mediating the use of donor human milk, and increasing volumes of mother's own milk. And then finally, we'll highlight some support and education that that can be shared with both families and clinicians. So first, we'll start by talking about the value of human milk. And the American Academy of Pediatrics, as well as the American Academy of Family Physicians and the World Health Organization, all recommend breastfeeding exclusively for the first 6 months. And the AAP as well as the AAFP encouraged continued breastfeeding despite the introduction of solids until at least 1 year. And then who recommends breastfeeding continue for the first 2 years? So, why are leading health organizations recommending breastfeeding? It really weighs heavily on what the research says about outcomes for breastfed infants. And human milk provides both nutrition and bioactive components that work synergistically. So this means that those bioactive components in human milk, they provide anti-inflammatory, antioxidative, growth promoting, hormonal, as well as epigenetic components that impact multiple organ systems or disease states. And we also know that attempts to add these components to formula just doesn't have the same impact as the constellation of those bioactive components in human milk. So adding them selectively to formulas is not going to have that same impact in outcomes for infants. And the bioactive components really help to program the stimuli during those first critical months of life and change the structure and function of an organ or pathway, making it less susceptible to disease states. And so human milk activates protective, health promoting changes. And during this critical period, if an infant is exposed to bovine based formulas, that infant can have an upregulation of inflammatory processes that increase the risk of different disease states. I'm sorry, I'm going to stop here just a minute and turn down this background. Hopefully, you can't hear people as they are coming in. I apologize about that. So, what is the evidence for human milk on short and long term outcomes for the healthy term infant? Well, it's apparent from a number of studies that human milk directly impacts things like otitis media, gastroenteritis, lower respiratory tract infections, as well as SIDS. And we've known that there's a relationship between human milk and its ability to protect infants from atopic dermatitis, from asthma and allergies, and particularly in those families that have risk factors for these morbidities. And we also know that human milk decreases the incidence of diabetes, of obesity, uh, different childhood leukemias, as well as it enhances neurocognitive outcomes for both full term as well as preterm babies. And the Agency for Healthcare Research and Quality looked at the evidence for both maternal and infant benefits in developing countries, and there is quite a bit of evidence that human milk has an impact on all of these complications. And we know too that human milk provides extra protection for babies who are ill or those that are premature. And it's really now considered a standard of care in the neonatal intensive care because it favorably affects the GI tract function and maturation. And so mothers who deliver their babies preterm make milk that is specifically suited to their immature babies. And their milk differs from the milk of mothers who deliver at term. This preterm milk has more protein, has more polyunsaturated fatty acids, as well as more sodium and chloride and more immunoglobulins. And preterm milk is, like I said, specifically suited for the special needs of that preterm baby. And there is a reduced incidence of necrotizing enterocolitis or NEC, and mother's own milk helps to protect from late onset sepsis as well. Preterm babies are growing their brains at an astronomical rate. And a preterm infant who's born at 28 weeks must double its brain weight by 100% in the first 8 weeks of life. And so, brain and central nervous system development are crucial during this time. And breast milk contains the exact amount of polyunsaturated fatty acids and other fats that are necessary for this brain growth and development. They are optimally absorbed and utilized due to their increased bioavailability. And numerous studies demonstrate that breast milk helps to protect these very fragile babies from both long and short term morbidities. So, what if an infant is NPO or cannot breastfeed for several days or several months? Providing oral care with colostrum and mother's own milk is an increasingly common intervention that has been shown to be safe and feasible in studies. We know that colostrum contains highly concentrated immunologic properties like lysosomes, immunoglobulins, and cytokines, and those help to provide a barrier protection and promote bacterial cell wall lysis, as well as anti-inflammation and immunomodulation. And human milk and or colostrum given via the gavage tube provides many vital immunologic properties to an infant. And research has shown, though, that these immune agents can interact directly with the oral mucosa, um, specifically when we provide oral care, and they're readily absorbed. And they help to coat the GI and the upper respiratory tracts to promote colonization with the mother's bacteria. So this helps to prevent respiratory and intestinal pathogens from invading the mucous membranes, which would be bypassed if it had been given through an NG or an OG tube. So I like to think of it as a door of, a door of protection. We're protecting right at that open door. And colostrum via the oral route is meant to be absorbed. It's not meant to be swallowed. And so it should be considered safe for all infants, even if they are NPO. Enhanced intestinal motility and maturation, including growth factors and enzymes contained in mom's own colostrum, may have been absorbed mucosally and or traveled to the GI tract, providing effects at the mucosal surface that enhance maturation as well. And there's clinical studies of the use of human milk in the NICU indicate that all human milk reduces the risks of neck. However, only mother's own milk has been shown to reduce chronic lung disease, things such as brain injury, sepsis, retinopathy of prematurity or ROP. And as mentioned before, human milk, specifically mother's own milk feedings, reduces the risk for preterm infants because of the GI protection it provides. It stimulates that growth and motility and helps mature those very premature intestinal tract. And so while human milk is beneficial for all infants, the scientific evidence suggests it provides additional benefits to preterm and vulnerable infants to reduce things like costly readmissions, extended lengths of stay, SIDS, and then time to full enteral feeds. And we know preterm infants are most likely to suffer from morbidities, to have higher death rates, and significantly increased costs of care over their lifetime as compared to term infants. And so overall health outcomes are reduced by using human milk. These are national savings, decreasing healthcare costs by improving the early nutrition by providing mother's own milk. And so, for example, respiratory infections could be reduced by over $5 million by utilizing human milk. And evidence supports that there's also a dose response relationship between human milk and improving newborn outcomes for infants. So we know mother's own milk is often referred to as medicine, and rightly so. Those first 28 days of life are a very critical period, and the dose of mother's own milk improves outcomes. So increasing as little as 10 mils per kilo per day can have a significant difference on an outcome. And mother's own milk at doses of greater than 50% during these critical periods has demonstrated to reduce the risk of those neonatal morbidities, including neck, BPT, and sepsis. So knowing that exclusive breast milk feeding in the first 6 months of life can result in numerous long-term health benefits for both mother and infant, the Joint Commission has incorporated a perinatal core measure for exclusive breast milk feeding that applies to healthy term newborns. And the Joint Commission believes that care processes and patient outcomes can be improved and sustained only through gathering and analyzing that performance data by an organized and comprehensive approach to performance improvement. And so evidence suggests that the prenatal and intrapartum period is critical for success of exclusive breastfeeding. And now, therefore, this one is recommended that all newborns greater than 37 weeks are fed breast milk only from birth to discharge. So at this time, I'm going to transition over to my colleague, Angela, who's going to discuss alternatives for mother's own milk. And this is going to include profit and not-for-profit human milk availability. So Angela?
Thank you, Jenny. And thank you for that amazing review of the value of human milk. And like Jenny said, I'm going to transition to review the benefits, limitations, and availability of donor human milk and donor human milk products as well, and compare those to mother's own milk. And so knowing that all it takes is just one feeding of a bovine formula to disrupt the normal gut flora, placing an infant at increased risk for infectious disease, as an alternative to reaching for formula when mother's own milk is not an option, pasteurized donor human milk is now more widely available. And we know that human milk, as Jenny just explained, contains nutrients that no synthetically derived product can offer. So after being voluntarily donated by lactating mothers, the breast milk is first screened and tested, and then it's pooled and pasteurized. So really the question here is there a need for donor human milk? And the answer to that question is yes. There certainly is a place for pasteurized donor human milk. And the science behind it proves that an exclusive human milk diet improves those morbidities and mortalities often seen in the very and extremely low birth weight infant populations. And so we see pasteurized donor human milk as a suitable feeding alternative for infants whose mothers are unable due to some certain medical conditions such as HIV or active untreated TB, or who may be unwilling or unable to provide her own milk. Often clinical sites have criteria to include certain patient populations to be eligible for donor milk, and often lists like this come into play. And so there are some limitations that really cannot be ignored when it comes to pasteurized donor human milk. It goes through a pasteurization process and ultimately causes many essential bioactive components to be lost due to the changes that it goes to in temperature. And one of those components that is impacted is lactoferrin. And lactoferrin is the most abundant protein found in human milk. And studies show that lactoferrin is not significantly lowered in a standard refrigeration storage period of about 5 days, but is dramatically decreased up to about 88% due to this pasteurization process. So this, when you combine that with the deep freezing of donor samples, this really may indicate why the donor milk outcomes are not really shown the same advantages of fresh maternal milk in terms of those reductions in the morbidities such as sepsis and necrotizing enterocolitis. We also see during the pasteurization process the bile salt stimulated lipase that aids in fat digestion, it becomes destroyed, as well as alkaline phosphatase, which aids in the downregulating inflammatory response, is also affected. And then looking at human milk oligosaccharides, or HMOs, really offering benefits on multiple levels. They are prebiotic, anti-adhesive, antimicrobials that really shape an infant's intestinal microbiota composition. They may also directly interact with the infant's intestinal epithelial cells or modulate immune cell responses and provide the infant with sialic acid, which sialic acid is potentially responsible for the brain development and cognition in the infant. And HMOs are the third most abundant component in human milk. And although HMOs are not affected by the pasteurization process, moms that have delivered preterm infants have higher concentrations of HMOs than those who deliver at term. And through research, 150 to 200 different HMOs have been identified in human milk, and not every mother makes the same HMO patterns. And so the structural diversity depends on maternal genetics and becomes unique between the dyad. And looking at nutrition for all mammals, it really begins before birth as a result of swallowing amniotic fluid. And so for the human infant, amniotic fluid contains high concentration of growth factors that target epithelial cells in the gastrointestinal tract. And these aid in the maturity, motility, and intestinal growth. And human colostrum, being a vital first food, is tailored to assist the newborn's transition to the extrauterine life. Specifically, mother's own colostrum provides essential components and functions that really donor milk is not going to be able to provide. And we know preterm milk is even more protective. So preterm colostrum has more protection than that's going to be produced from a full-term delivery. And so the majority of donor milk that is offered is provided by infants of term mothers or moms who are further in her lactation journey. So therefore, the benefits of colostrum, specifically mother's own colostrum, are not going to be available during a critical period in the neonate's life. And so, for example, humans receive IgG antibodies via the placenta during that third trimester. And that provides systemic immunity for the newborn against specific diseases, really for about the first 6 months of life. So when an infant is born early, they're missing this crucial reception of these antibodies. So what we can do is mother's own colostrum in preterm infants has more cytokines and enzymes that can be directly absorbed into the buccal mucosa to aid in the resistance of this external bacteria. And our very small babies are likely to have exaggerated inflammatory responses with really little protection to stop it. And this inability to produce a counter-inflammatory response puts them at a higher risk for a more systemic response. And so these cytokines found in colostrum are going to work to down-regulate any inflammatory responses. So if oral care with colostrum is provided, it really can intervene oral colonization in the mouth, like Jenny said, right at the door, to have the effect of local immunity. And really, as lactoferrin is providing that strong protection. And a protein called TLR4 helps to regulate the body's immune response to this external bacteria. However, when we're talking about preterm infants specifically, it regulates cell differentiation and intestinal growth. So after birth, the intestines become colonized with bacteria based on the new environment. And if an infant is born prematurely, the TLR4 is also immature and can act uncontrolled. And it can shut down the oxygen supply to the intestines, which is where we see the cell death in necrotizing enterocolitis. Epidermal growth factor is a substance found in human milk, which blocks the activation of this protein that's instigating this intestinal damage. And a study showed how premature infants' TLR4 was turned down with the pretreatment of human milk. The lead author of this study, a neonatologist, Dr. Misty Good, stated that in her research, quote, taken together, our findings show that the epidermal growth factor is a key factor present in breast milk that prevents the onset of NEC in 2 ways. EGF prevents intestinal cells from dying while at the same time restoring the cell growth that promotes gut healing. And again, the GI tract of a premature infant is also immature. It's not able to recognize the difference between good and pathogenic bacteria. And in human milk synthesizes soluble CD14, which is a pattern recognition molecule. Soluble CD14 educates in a molecular way for the GI tract to distinguish between the good and pathogenic bacteria, and essentially educates the immature GI tract to begin to distinguish between the two. And looking at colostrum, colostrum has very high concentrations of soluble CD14, which is being passed to the baby to theoretically help the good bacteria in the breast milk form a healthy relationship with the bacterial enteral site crosstalk in the gastrointestinal tract. And here a Swiss study looked at blood and human milk samples. And what they found is that the amount of soluble CD14 was 20 times greater in human milk than it was in serum. And you can see that it was even higher in colostrum. And one of the other things they found was that the bacterial crosstalk actually lasts a lifetime, promoting long-term intestinal health. So I know we've talked about a lot and I don't want to lose anyone, but I want to just go back to recall from earlier. We talked about pasteurized donor human milk being pooled. It's pooled and pasteurized, and it's often coming from mothers with established milk supplies really well beyond the colostral phase. So it's really because of this that infants receiving donor human milk over mother's own milk, they're not going to be getting the same dose of extra protection. And then here in the intestines, what you see on the bottom is the intestinal epithelial cell lining. There's epithelial cells in the lining of the intestine. And we have bacteria in the lumen of the intestines. So the green objects on the screen really represent our good bugs. We have healthy bugs in our GI tract, but we also have nasty pathogens, and those are represented by the purple bugs. And so in the presence of milk oligosaccharides, some of the good bugs can metabolize the oligosaccharides and really have a growth advantage and really start to move or kick out the bad pathogens. And there's been, as more recently, huge interest in oligosaccharide research. And really, they're finding that oligosaccharides are resilient and found still intact in the feces of human milk-fed infants. They're found bound to the virus or pathogen, but what they're not finding is they're not finding these HMOs in formula-fed babies. So what they're essentially doing is keeping the pathogen intact and combating their spread. So they're moving them through without letting them impact the baby. And although HMOs, like I said, are not impacted or affected by the pasteurization process, we've already talked that they're tailored to specifically the mother's genetics. And so donor milk isn't going to provide the same as mother's own milk in way of tailored protection. Okay, so we've talked a lot about the wonderful protective components of mother's own milk and just how valuable it can be for all babies, but certainly for those born prematurely or with medical complexities. And so knowing that there are many variables to mother's own milk being available to provide to babies, especially NICU babies, this is where we recognize that pasteurized donor human milk has a place. And again, we spoke that it only can take one feeding of a bovine formula to disrupt the infant's normal gut flora and placing them at risk for increased risk for infectious disease. And so with pasteurized donor human milk, the option to bridge the gap and avoid introducing this artificial nutrition is now more widely available. And I really say bridge the gap because ideally pasteurized donor human milk will not be used as a long-term solution or even replacement for mother's own milk in most clinical scenarios. And for the reasons we've just reviewed, knowing that mother's own milk offers benefits that cannot be replicated even with donor human milk, we continue to use donor milk with caution. And so we recognize it has its place, of course, and provides an important clinical solution to many of the common NICU patient scenarios on our daily basis we care for. And so with that, we're going to shift a little bit to review pasteurized donor human milk and human milk derived products that are available today. So we're going to start with a little bit deeper look at the Human Milk Banking Association of North America, or HMBANA. So a few things to know about HMBANA accredited milk banks. Milk is donated by mothers, and they're not compensated for their donation, as HMBANA milk banks operate as nonprofit businesses. Donors are screened to ensure the safety of the milk, and you can see here that the process, the screening process is quite in depth. And really that's in order to detect any concerns with the donated milk and to ensure the health of the mother, and including things such as bloodborne illnesses, history of smoking and tobacco exposure, and alcohol consumption. And really the key here is healthy. The screenings begin early and are ongoing throughout the donation process, and a trusting relationship is developed throughout the process. And the milk is meticulously handled throughout the entire process to ensure a safe, high quality product is offered. And just a little bit of history here. The Floating Hospital for Children in Boston, Massachusetts launched North America's first milk bank, and that was back in 1911. And this was really before home refrigeration was available, and in the summer months, food, including milk, cow's milk was a popular option at that time to feed babies. It spoiled much faster. And so as a solution, the hospital opened a milk bank for an option for safer milk storage at that time. And then later, Humana was then founded in 1985. And they accredit milk banks across both the United States and Canada. And listed here are their current 31 member milk banks. And then there are also for-profit milk banks. So we're going to just take a second to look at a few of the for-profit options as well. The first is Prolacta. Prolacta was established back in 1999, and it is a privately owned life sciences company. They have human milk-based products, and they became available in 2006 to the hospitals. They offer human milk-derived fortifiers that can be added to both mother's own milk or donor human milk. And they also have ready-to-feed milk-based feedings as well. And their goals are to work to improve the health outcomes, improve growth rates, and reduce hospital costs in the neonatal population. Next is the Helping Hands Milk Bank, which is operated by Prolacta. And they work under a unique mission, which is really to integrate two compelling goals, which is obviously to collect excess breast milk from the qualifying donors for use with premature infants, while also simultaneously giving back to the community in a significant and meaningful way by financially supporting a selected charity. And the charity that was selected was the Susan G. Komen Foundation. And Prolacta donates $1 for every ounce of milk that is donated. And really, they found that this was an important cause because of the studies that show a correlation between breastfeeding and the reduction in women's risks of developing breast cancer. And so Prolacta supports a strong alignment between breastfeeding, breast milk donation, and breast cancer research. And then Medilac was founded really to find a way to ensure that every baby who was needing breast or donor milk, breast milk, was able to get it. And so the product Medilac Benefit is a commercially sterile product. It's packaged in a hermetically sealed pouch. It's shelf stable and stable for up to 3 years and can be stored at room temperature, which makes it more of an option or a solution for areas where there's limited capacity to safely store our deep frozen donor milk. So this product has been heat processed to be commercially sterile, and once opened remains fresh for up to 7 days. And their products on the market range from 18 to 24 kilocalories per ounce. And as well, Medilac has recently announced a new product that will be coming soon, which is a fortifier. It's a 100% human milk infant nutrition liquid fortifier called Fortify MVP. So new human milk-based products for Medilac are coming soon. And then lastly, NICU. NICU is an Oregon-based company, and they're dedicated to delivering the best possible nutrition to our at-risk infants. And they work with hospitals, NICUs, pediatric clinics, and other healthcare facilities, really whose primary focus is premature and low birth weight infants. And so per their website, they are the only clinically stable 24-calorie milk on the market. They have two products, an HDM Plus and an HDM Boost, and their products have no preservatives, fortifiers, or artificial ingredients. And they also feature a longer shelf life of up to 12 months. And so it's no surprise that preterm infants have unique nutritional needs. And we know that up to 17 weeks of their final growth is occurring outside of the womb rather than intrauterine. And we know these last weeks are a period of rapid growth and maturity of their major organ systems. And we know fetal weight is going to double in that time. Length is going to increase by 25%, and 70% of every calorie is going to be used for brain growth. So mom is no longer able to do the work for them. They're now outside the protective environment of the womb and are responsible for managing the energy expenditure of the extrauterine world. And while the nutrient composition of human milk is ideal for term infants, specifically the protein and mineral content of human milk is insufficient to meet the needs of the rapidly growing preterm infant. And this is really where fortification of human milk becomes indicated in order to supply nutrients required to support this rapid rate of growth, as well as bone mineralization. So we just talked about the importance of managing the growth of a preterm infant, but how we grow them is important to their long-term health outcomes. Infants that receive human milk diet are less likely to have this excessive growth. And really, it's important to remember we want good growth, not just rapid growth in these infants. And so adverse effects of excessive growth include things such as obesity, hypertension, insulin resistance, and diabetes, as well as cardiovascular mortality. And so really you can compare it to that of an athlete that's looking to improve their strength and performance. They're really looking to add, good growth. They want lean muscle, not this excess fat, which is going to put additional fat around their heart and placing them at risk for developing things such as insulin resistance. And so you can apply the same to the preterm infant. The goal is to provide them optimal nutrition that's going to have good growth rather than just rapid growth that's more similar to that of a healthy breastfed baby. And one of the many benefits of mother's own milk is that it provides a decreased risk in NICU-related morbidities. There's a large body of research supporting that an exclusive human milk diet reduces NEC rates as well as severity. However, in contrast, the use of donor human milk in studies has not shown the same reduction of sepsis, chronic lung disease, or a positive impact on neurodevelopmental outcomes in the very low birth weight infants, despite its reduction in NEC. And furthermore, we know that our donor milk fed babies gain weight slower. And so again, we've talked about donor milk being provided by mothers who deliver term infants. So this, in addition to the effects of pasteurization, really is another reason donor milk lacks sufficient components to meet the needs of the preterm infant. And going back to thinking of breast milk as a medicine, it's essential it's provided with as many benefits as possible to provide adequate nutritional support. So what's the cost of all of this? This study here by Meyer and Associates illustrates the importance of prioritizing mother's own milk feedings to optimize the dose and importance of exposure during critical periods. So the rapidly accumulating evidence suggests that bioactive components of human milk provide morbidity-specific protection via different mechanisms during different exposure periods during the NICU hospitalization. In our preterm infants, higher doses of human milk are associated with lower risks of things such as enteral feeding intolerance, late onset sepsis, NEC, chronic lung disease, ROP, neurocognitive delay, and even rehospitalization after the NICU discharge. And this article suggests the implementation of evidence-based quality indicators for measuring and benchmarking human milk use in the NICU, which really goes back to that PCO5 of the Joint Commission, working to maximize the benefits of an exclusive human milk diet. And this article was published in the Journal of Pediatrics, and it reports on the costs of morbidities. And this study provides really the first collective estimates of the direct costs related to the morbidities during the NICU hospitalization in the surviving very low birth weight infants. And their results indicate that both the presence as well as the number of morbidities are associated with significantly higher costs, NICU costs, even after controlling for things such as birth weight, gestational age, race and ethnicity, gender, and primary payer. And so our very low birth weight infants represent a very small portion, only about 1.5% of our live births in the United States, but the cost of NICU hospitalizations for this group ranks them among the most expensive of all patients. And these birth weight and maturity related healthcare costs are further increased by the fact that our surviving very low birth weight infants are susceptible to a number of costly yet potentially preventable morbidities that often require additional treatments such as ventilation or surgery. And these morbidities not only increase NICU hospitalization costs, but increase the risk of long-term chronic illnesses, rehospitalization, and developmental delay in this population. Thus, this is really showing that these morbidities are not short-term. They have long-term economic consequences for society at large. And looking here, the listed figures are from 2013. So we really can expect that they have increased since then and have become even more significant. And so a tool that's available in order to model the effect of mother's own milk feedings is the Medela Human Milk Calculator. And this calculator is pre-populated with figures identified in relevant literature, and it allows the hospital clinician to input their current mother's own milk feeding data and then look at their incidence of NEC, late onset sepsis, and or BPD. And then they can adjust their feeding goals to model possible incident reductions. And this is largely modeled after Tricia Johnson's research at Rush University. And the calculator uses figures such as the average daily dose of mother's own milk, exclusivity within the critical period of the first 14 days of life, and the average percentage of mother's own milk at 36 weeks postmenstrual age or at the time of discharge to identify the possible incident reductions within these morbidities. And this tool is available on the medela.com website that's listed here. And then this slide offers really a macro view of the very low birth weight, annual admissions, and the impact of human milk dose variance. And so assuming that all very low birth weight patients receive in that low or no human milk category, this indicates the hospital's cost directly related to morbidities. And the same holds true with the high human milk, which is resulting in less morbidities, equating into less cost. And so the column all the way on the very right rolls up the difference in millions, and you can easily appreciate the significance here. And so just for an example, a hospital that has 1,000 admissions, 160 of those are very low birth weight infants. And that's resulting in a variance of up to or more than $5 million between the low and no and high human milk groups. So easy to see that the potential cost savings here are significant. And in really the current healthcare climate, any cost savings is crucial, and this is very significant. At this time, I'm going to actually pass it back over to Jenny. Jenny, I'm going to pass it to you to review the available research and technology to effectively initiate, build, and maintain mom supply so that we don't have as much reliance on donor human milk.
That's great. Thank you, Angela. So in the previous slides, really discussion about the inherent value of mother's own milk over donor human milk has really been detailed nicely. Thank you for that, Angela. So the question needs to be addressed is how can we increase volumes of mother's own milk to minimize or eliminate the need for donor human milk? And we know that mothers work diligently to try and keep up with demands of producing milk, but many times they struggle with producing adequate volumes. I saw that, time and time again. And decreasing milk supply is one issue many mothers who express breast milk for their NICU infants encounter. And too often we'll hear mothers of NICU infants comment that they aren't producing enough breast milk, or we witness that maybe initially their supply appears to be sufficient, but then it decreases. So the use of a breast pump to express human milk is really necessary to initiate, to then build that supply, and then help her to maintain those daily milk volumes needed to ensure the provision of an exclusive human milk diet is available over the length of the NICU stay and beyond, if mom continues. And we know that all breast pumps aren't created equal. There's different technology, there's different motor types, they differ in pump strength and durability. And all of these factors influence how well milk is removed, the pain they may cause, and then the potential decrease in mothers' milk supply, increasing the need for donor human milk. And so every mother who wishes to express milk for her compromised baby, or any baby, I feel like all of our babies, even not, those not in the NICU, are at risk, but should have the access to evidence-based technology to help them meet those sufficient volumes and hopefully help decrease that need for donor milk. And so, because mothers look to health professionals to answer questions about breast pump differences, it's really important that clinicians have an understanding of the differences in which breast pumps offer evidence-based technology. And so we know those first 2 weeks after birth is a critical time period for mothers to initiate a milk supply in order to prevent problems with low milk volume. There's complex hormonal, anatomic, and biochemical changes that occur during this time that really appear to program future milk production. So complex processes, meaning, one process is going to influence another, are really interrelated. For example, the mammary gland is extremely sensitive to the effects of prolactin and its effect on milk yield programming during this time. And interestingly enough, the dairy industry has aided in determining this critical period for programming milk yield. We know that, the dairy industry is very invested in cows lactating because milk is a commodity. And there was a study that assigned cows randomly to either be milked 4 times daily during the first 3 weeks after birth, or cows that were milked 2 times daily post birth. And then after 3 weeks, all of the cows were milked twice a day. And what they found was that the cows that were milked 4 times a day had greater milk yield during the first 3 weeks and throughout their entire lactation period. And then, furthermore, the biopsy of the mammary glands revealed greater secretory cell growth and differentiation and less secretory cell apoptosis in the cows that were milked 4 times per day. So, greater stimulation to the breast resulted in more milk making cells and caused a growth of secretory cells when they were most sensitive to prolactin, that in turn affected not just that time period, but affected long-term lactation. So new evidence suggests that babies' feeding behaviors have a really important role in determining this lactation success. And those first few days post-birth, an infant sucking is not biphasic because there's minimal amounts of colostrum. And so the human infant sucks in response to the volume that he or she is getting. So this results in a sucking pattern that's unique to human babies. And I know we've all seen this very when there's small amounts of milk, the infant responds by increasing sucking rates and pressure. And so the breast is getting almost 2 times as much stimulation as when the milk comes in. So when the baby doesn't get milk, he or she will suck harder. And that low milk flow, or non-nutritive sucking patterns, are characterized by really rapid sucking rates and those long irregular pauses, because the sucking rhythm and rate is really a function of the milk flow. And the ability to alter this sucking rate and rhythm depending on the milk flow is unique among humans. And these unique infant sucking patterns in those first few days of life appear to program mother's breast for optimal milk production. And so, much like the secretory cell growth and differentiation identified in the cows that were milked, more often, early newborn sucking is really a potentially viable and safe intervention to provide at risk mothers with additional breast stimulation for optimal milk production. And that unique sucking rate and rhythm is applied to the breast intensively over those first few days post birth. So, this infant sucking pattern does more than just get the milk out of the breast. It actually appears to program more secretory tissue and prolactin receptors under the high concentrations of prolactin. And so, mothers who are breast pump dependent and who don't use special breast pump suction patterns that mimic this do not receive that stimulation to the mammary gland and can result in declining milk volumes. So, challenges with declining milk volumes can be reduced with appropriate clinical intervention. And it's important that a breast pump suction has patterns that mimic that of the newborn infant for reasons that supported in multiple research studies. And so clinical studies, which we'll review in just a minute, indicate a pattern that mimics newborn initial sucking of irregular cycles and suction strength interspersed with long pauses works best to stimulate mom appropriately in the absence of a healthy term baby, thereby programming those secretory cells for long-term milk production. And so once volumes begin to increase, indicating the onset of lactogenesis 2, and typically we see that, between say 2 to 4 days, mothers then should use a two-phase sucking pattern similar to an infant sucking behavior once a mother's milk does come in. And so that pattern, and we see that, when we have a normal healthy term baby at the breast, starts with shallow and rapid sucking, and then followed by slower and deeper pattern to remove milk. And so 3 clinical trials demonstrate improved milk volumes with the combined use of programs that mimic the initial newborn sucking behavior, followed by that biphasic sucking pattern once mom's volumes began to increase. And so what these studies uncovered is moms who are pump dependent produce more milk more quickly when compared to those mothers that use the biphasic or the two-phase program alone. So I used to tell moms when I was at the bedside, it's really important that, I know we're looking at the focus and wanting to see the milk. And yes, we're going to get that colostrum, but what's important in these first couple of days right now is the stimulation. So very important. And these 3 studies by different researchers looked at various groups of mothers with intensive care babies. And Meyer and Associates conducted a randomized controlled trial of women whose infants were all preterm. They were born less than 34 weeks. And then in the second study, Torowitz and Associates evaluated mothers whose term infants were admitted to the cardiac intensive care at Children's Hospital of Philadelphia. And then lastly, Post and colleagues studied pumping mothers across the board. So those of term, late preterm, as well as preterm NICU babies. And although these studies did vary in methodology, they all included women with intensive care infants. And so important to our previous discussion of other risk factors for delayed lactation or suboptimal lactation, the parents in all of these, or the participants in all of these studies were diverse. So in other words, they weren't excluded for prematurity, for advanced maternal age, for how they were delivered, or glucose intolerance. So really want to take just a little bit deeper look at each of these studies. So the first study was done by Dr. Paula Meyer and colleagues, and it was published in the Journal of Perinatology. It was a blinded, randomized controlled trial with 105 pump-dependent moms of preterm infants. And so this gray line here is representative of the volumes of a healthy term infant mom and what that dyad achieves. And so that's really our gold standard. So this data comes from an older study with moms whose babies were healthy. They were multips, they were part of a La Leche League group. And what they did was monitor milk volumes for the first 2 weeks by measuring test weights. And so this has been a standard of healthy term babies that's quite frequently used in research. So the yellow line here shows the milk output of a mother using the biphasic program only. So it's quite good, but it doesn't reach that line or that goal of at least 500 mLs per day. So now you can see the orange line, obviously much better output. So when we look at day one, there's not a lot of difference, but by day three, the experimental group started to pull away from the control group, and they continued to do so for the remaining 2 weeks. And you can see on day 6, mothers using the initial pattern that mimics a newborn's initial sucking pattern, followed by that biphasic sucking pattern, were reaching their goal already. And then they kept going. They followed that perfect line of a term breastfeeding infant. And so the conclusion of this study was that breast pump suction patterns that mimic the unique sucking patterns used by healthy term breastfeeding infants during the initiation and the maintenance of lactation are more effective, they're more efficient, more comfortable, and convenient than other breast pump suction patterns. And I think it's important to point out, many moms, one of the reasons they quit pumping is because they don't have enough milk. The second study was done by Torowitz and colleagues and published in Breastfeeding Medicine in 2015. And this was a prospective cohort study. So there were 62 mothers. These babies were all term. They were less than 6 months old, and they were either born or diagnosed with congenital heart disease. And so all of these moms began with a pumping pattern that mimicked a newborn's initial sucking behavior, so that very erratic pattern, followed by a biphasic sucking pattern. And you can see in comparison to the gold standard, that healthy term-born infant, that the initial program that mimicked the normal newborn behavior followed by the biphasic pattern can help pump-dependent mothers of term infants as well achieve a similar amount of milk. And then the third study by Post and colleagues was published in the Journal of Perinatology in 2016. And this was an observational study that included 130 pump-dependent mothers. And this was a combined group of mothers and infants that included, they had term, late preterm, and preterm infants. And they compared time to secretory activation, time to full milk production, and then overall daily milk output. So again, we'll compare both groups to our gold standard. And you can see that the moms that only used the biphasic program did not achieve the milk volumes comparable to that healthy term mom-infant dyad. And then once again, this study showed that the moms who used the initial program that mimicked that normal newborn behavior in the beginning and then transitioned to the biphasic pattern is more effective at achieving secretory activation and an earlier adequate milk supply than that standard biphasic program alone. So the irregular breast pump suction patterns can be used successfully for mothers of preterm up to term infants who are breast pump dependent during the establishment of lactation. And so looking at all of these studies together, you can clearly see the advantage of a mother who's using breast pump suction patterns that mimic the infant sucking immediately after birth, followed by a program that mimics a healthy infant sucking once mother's milk has come in. And so when we know that when moms can supply their own milk to their own babies, the babies are going to reap significant benefits, as we've discussed. And there's also long-term emotional and health benefits for the mom when they can supply their infants with their own milk. And then overall, the economic benefits to our society as a whole go unmeasured. And we know pumping's not easy. That's obvious to anyone who has pumped or anyone who has helped a mom pump for any period of time. Just a quick story, my sister-in-law delivered my niece just over a year ago, and she had many risk factors for delayed lactogenesis. So I talked to her about the importance of early breastfeeding, and if she did have to pump, that it should not be long term. My niece was born and she was on the small side, and we did expect this because her sister, who was born 5 years prior, was only 4 pounds when she was 36 and a half weeks. And so she did great breastfeeding initially, but then she was very sleepy. She couldn't sustain any sort of latch or active sucking after that initial feeding. So she did ask about pumping, but was told that she had done very well breastfeeding in the first hour. So just to keep trying. And I don't know about you guys, but I know in practice I had said that many times. Um, but it wasn't just the sleepy baby she had up against her. It was the number of risk factors that she had prenatally that was really concerning for delayed lactogenesis. So she met the criteria for discharge. About 36 hours later, she had breastfed. My niece had voided and stooled, so she was kind of checked all those boxes, so she was good to go. And my brother and sister-in-law were anxious to get her home. It was in the middle of the pandemic, and my 5-year-old niece was really wanting to meet her new baby sister, and she couldn't visit in the hospital, so they did end up being discharged. And over the next several days, my niece became more alert and awake. She latched well, but there were periods where she just didn't sustain that latch for some of the feedings. And she was jaundiced and was being monitored. And I knew we needed to get her set up on a pump to at least get some more appropriate stimulation going so that long-term milk production was going to be sufficient to meet my niece's needs. And, I didn't want to put any pressure at all on my sister-in-law. I had breastfed one of my children, and the other one I had to stop early for other reasons. And so I didn't want to put pressure on her at all. But I knew in her heart that she was set on breastfeeding because she had not chosen to with my older niece. And I also knew that her personality, if she couldn't meet this goal she had in mind, it was going to affect her long term. And so I had a separate talk with my brother about all he could do to support her. And his initial response, like we've heard from many support people, is, can't we just get formula and, work on that? And that he actually said that in front of my sister-in-law. It didn't go over very well. Um, so I talked to him just about what he could do about washing pump parts, ensuring she had food, ensuring she had a full glass of water, and all so she could focus on breastfeeding and getting sleep. And it's so important that we understand the support for everyone needed to get breastfeeding off to the right start and hopefully be able to help them continue to meet those long-term goals. And I say that too with the supportive people at home is because we know and we've heard that lactation support in the hospital has either been cut or has FTEs have been decreased, and nurses just are spread thin now. And so it's very hard for them. It's not that they don't want to help by any means. It's just hard for them to meet all of those patients. So it's very important that we incorporate support people that are close to mom that can help her as well. So although my niece was not in the NICU and in this scenario, I'm happy to report she was able to breastfeed for 9 months, and she did have to supplement intermittently because she never came to what we refer to as full volume. And I can't help but think, had we got her started earlier, had that outcome been different, but we can't look back. But she was committed though and breastfed and pumped as needed. So happy to report that I have a healthy growing niece today that's a little over a year old. But all of that to say, I'm going to turn it back over to Angela. So she's going to discuss some support and some education that's really important to offer to moms and to families and clinicians like yourselves, many of you are online now, that we all work together to provide help mom and provide the most vital medicine to an infant. And we know that that is going to be mother's own milk. So Angela, I'm going to turn it back over to you.
Great. Thanks, Jenny. And what an awesome real life example of the ongoing need for this support and education of our moms and support people. And so really offering the opportunity for families to make informed decisions has become standard of care. And it really is no different when it comes to the conversations around breastfeeding and providing human milk. As healthcare providers, we should provide guidance on both specific short and long-term benefits of human milk. And families should be aware of the very specific components that human milk has that can help protect their baby. And nurses play an active role in the responsibility to serve as patient advocates, informing families about really the why behind human milk and why it's so important for the vulnerable infants. And really, it's important to include those specific examples on the how mother's own milk is going to be helpful. And if you think about other areas of healthcare, healthcare professionals do not withhold factual information that's going to influence or inform families' decisions. And so providing families with breastfeeding information, it should be no different than other discussions regarding ongoing management of the patient. And so all parents should be supported in these informed decisions. And through this, we don't want to forget about our support persons, our significant others in this education. The level of support from significant others plays a large part in a mother's willingness and even ability to continue to express, pump, or breastfeed to provide human milk to the baby. And really, although some moms may have initially not planned on breastfeeding, just encouragement for her to, express her milk, just, begin expressing, pumping, or placing the baby to breast if able, is really a great alternative or compromise within this informed decision conversation that we have. And really focusing especially on those moms who were hesitant or not wanting to provide her milk initially, it's important to emphasize the need for providing mother's own milk during the most crucial periods. And we know that days, the first day to 14 days, the first 2 weeks is the most protective if we can get milk within that period. And even the first month is even better. And it's not really only about direct breastfeeding, but the education and educating of families about the science and the value of human milk for these babies, and messaging to her that her milk is a medicine that her fragile infant needs, and the infant needs her medicine that only she's going to be able to provide. And we know that this is dose dependent, as Jenny already mentioned. So the more exclusive and the longer it's provided is going to equal better outcomes. And in a 2013 publication, Dr. Meyer showed that at Rush University Medical Center, they were able to have 98% of mothers choose to pump breast milk for their babies after hearing the value of her milk for her sick baby, even though 50% of those mothers intended to feed formula. And so this really makes clear how we as clinicians can really make this difference in increasing our initiation rates and ultimately improving the duration and even exclusivity with this informed consent conversation and providing them with accurate information. And really all bedside clinicians should have this human milk specific education. Nurses being the champions of all things, and especially breastfeeding and lactation support in the NICU and maternity populations, it's incorporated into the daily care. Does not come without challenges though. Nurses wearing many, many hats these days do not just have one job and often not just one baby to take care of. So our higher acuity units really have more of a life-saving priority. And as the levels, go down, there may be more breastfeeding input, being a more increased part of the job. But some really may just feel that as long as mom gets a little colostrum for oral care, this is enough. And so they're also responsible for balancing the needs of the mother with the responsibility to provide care to the infant. And we all know, as many of us on the line are nurses, that managing the mom and the family with the needs of the baby really is challenging and certainly puts added pressure on the nurse. We also have to look at the speed of the milk journey as an added challenge. Delays in getting colostrum following delivery, especially of a sick NICU baby, and really determining whose role it is, right? We add lots of different caregivers in this situation where mom delivers, transitions from L&D down to the postpartum unit, and the baby's taken to the NICU. We have many caregivers involved at this point. So really determining whose responsibility and who's going to set mom up within this crucial window to ensure she has the ability to begin expressing. And we really, again, like I said, starting even as early as in labor and delivery, we can have mom set up with this option of having a hospital grade double electric breast pump to ensure that she has the option and the ability to pump within that first 1 to 3 hours after delivery. And we want her to be able to pump early and pump often. It's that classic 8 or more in 24 that we're looking for. And we really also want to look at, is there an opportunity to allow mom to pump at the baby's bedside? That can help the mom and baby bond. It can also help increase essential milk producing hormones, such as prolactin and oxytocin. It's going to help boost mom's supply, as well as provide tailored immunity to that infant's environment. And so when an infant, again, in this such scenario, is unable to eat by mouth, is potentially NPO or not safe to eat by mouth, as healthcare providers, we should support mom in providing oral care with colostrum. We've talked a lot about those benefits that outweigh anything that can come from donor milk in mother's own milk and mother's own colostrum. We know that colostrum interacts with the lymphoid tissue in the oropharynx and in the gut, and it stimulates growth of the intestinal mucosal surface area and promotes the development of digestive enzymes. And this practice may decrease things such as clinical sepsis, that it may inhibit secretion of pro-inflammatory cytokines, increase the level of circulating immune protective factors, as well as potentially reduce the incidence of things such as NEC, bacteremia, ventilator-associated pneumonia, and it may also reduce the time that the infant takes to achieve full enteral feeds in our smallest of babies. So lots of great positives that can come out of that early vital oral colostrum care that we can inform and advocate for. And as research has shown and demonstrates that colostrum for oral care is well tolerated by even the smallest and sickest of infants. Like Jenny said, it's not meant to really be swallowed. It is meant to coat the oral cavity and give that immune protection and oral colonization right at the mouth. And so the other thing, again, offer praise. We want to, like Jenny said, and the real life story, pumping's hard. We know that a lot goes into it. Moms have to be dedicated, especially pump dependent moms. And right after delivery, a lot of things are going on. And so we want to offer praise for, really all of the efforts that are being made during this time. And I would be remiss, again, this is top of mind for most healthcare providers at this time, but wanted to just review the current situation with the COVID-19 pandemic and really the associated challenges that have then affected breastfeeding. And so the resounding recommendation of the CDC, UNICEF, World Health Organization, and the AAP is that breast milk is the cornerstone of infant survival. It's not just a food, it's boosting the baby's immune system and preparing them for lifelong health. And the great thing is there's been no evidence of coronavirus being transmitted through breast milk. There's 2 research studies right now that Medela is supporting, one at the University of San Diego and one at the University of Idaho. They're working to confirm these early findings, again, that coronavirus is not transmitted through breast milk. However, that SARS-CoV-2 antibodies are being found in breast milk of women who have recovered from the COVID-19 virus. And so this is obviously very reassuring and just another way that mother's own milk is showing and proving to provide tailored, unique protection. There are also multiple presentations from leading experts in the lactation community who provide accurate information and research to address concerns and really the ongoing benefits of human milk during these unfamiliar times. And these complimentary webinars are available on demand on the Medila's professional webpage. And so just wanted to take a moment to thank everyone for joining us today. We have reviewed a lot of information regarding human milk, the benefits of an exclusive human milk diet, while also acknowledging the limitations that come along with pasteurized donor human milk. And so to just review some takeaways, really it's clear that mother's own milk is the most protective and should be used prescriptively. Really, it's truly a medicine. We're initiating milk supplies early and often give mothers the best possible start to obtain those adequate milk volumes. And clinicians really must work to frame an evidence argument to prioritize mother's own milk over donor human milk with payers as well as hospital administrators, as we recognize donor human milk is expensive, but it also does not provide all the needed properties necessary for the desired clinical outcomes of our population. And so in summary, human milk is the preferred nutrition for all infants, as it's research proven to improve outcomes, especially for those babies born premature. Our colostrum of the preterm delivery is the most protective and has more cytokines and enzymes that are going to provide that local immunity. And similarly, we've recognized that preterm and term milk do not look the same. Our preterm milk has additional components that the preemie is no longer going to be benefiting from intrauterine. And we know that our pooled donor milk is most likely not going to offer these preterm specific benefits. And lastly, while the nutrient composition of human milk is ideal for a term infant, we know that protein and mineral content of human milk is insufficient to meet the needs of our rapidly growing preterm infants. And so because of this, we recognize the need for fortification to support these growth needs. And ideally, really, as clinicians, we should appreciate that we're not only impacting the infant's health while they're with us in the NICU or in the hospital, in the maternity, but really that we're setting them up for lifelong protection. It goes well beyond the time we spend with them. And so to close, we wanted to share this video with you. It is from 2013, so some of the noted breastfeeding initiation rates have improved since this time. But the story itself really exemplifies many patients seen on the daily in the postpartum units, NICU units that many of you on the call care for on the daily. So we'll share this video with you.
At first, oh my god, it hurt. The contractions were hurting really bad. And then I had a shot, and I was like, oh my god, I can't wait to get through this. And then when I pushed her out, I don't know, I wanted to cry. So happy. It was so beautiful.
When she first came out, I'm like, I'm a dad, you know what I'm saying? Like, my life is something different now. When I woke up this morning, I felt different. I didn't feel like the same person.
In this area, we are plagued with low breastfeeding rates and corresponding high infant mortality rates, and the two things go together.
I just want her to be a good mama, and I just want her to be there for her daughter.
How do you feel about breastfeeding? It wasn't easy, but it's starting to get easy.
Yeah, because at first she didn't even want to do it, but I personally feel like the natural way is the better way, you know what I'm saying?
We both feel that way.
You know, I just want her to be strong.
The breastfeeding initiation rate in the United States is about 75%. The breastfeeding initiation rate at St. John Hospital is 50 to 55%. So we have a lot of work to do.
I love her.
Thank you so much, Jenny and Angela, for that presentation. It was wonderful. We do have a little bit of time for questions and answers. My coworker, Cameron, posted a link for the evaluation. So if you can click on that once we're finished today, that would be much appreciated. Jenny, I love the personal story of your sister-in-law that you shared with us. That was great. And I also wanted to wish everyone, all the NICU nurses, a happy belated National Neonatal Nurses Week. I know that was last week. And also, as you all know, September is NICU Awareness Month, so we're all celebrating that as well. There was a question that came in the chat earlier on in this presentation. Will the slides or an outline with research citing be available to the attendees? The handouts were sent out with the link that was emailed out to everyone yesterday. If you don't have the handouts any longer, feel free to email education@medela.com and I'd be happy to send those out to anyone that still needs them. I'm not seeing any questions come in via the chat. So we can wrap it up for today. I just wanted to thank everyone again for joining us today for this webinar. It was great to hear this information. I also wanted to let everyone know that registration is now open for our October 20th webinar. You can visit medelaeducation.com for that. And I wanted to also thank everyone for that joined us last week for our 15th annual Global Symposium. We had over 1,400 attendees worldwide, and the on-demand sessions are now available. And the link to register, if you missed the live symposium, you can click the bar at the top of the page on medelaeducation.com to register for the on-demand webinars. But thank you everyone for joining us and have a
Kim.
good afternoon.
Oh,
Yes.
Kim.
Yes.
This is Jen.
Oh, you're muted, Jenny.
Oh, am I muted?
Oh, now you're unmuted.
Okay. I was going to say I did see one that I can appreciate at the very top. We need to differentiate between processing of shelf stable and frozen donor milk. There is a huge difference in immune factors, and I totally can appreciate that. And I think that would be a whole nother topic. But yes, I do agree there is a difference between the processing of those long-term shelf-stable donor human milk compared to frozen donor milk. So thank you for that
I
comment.
apologize, I missed that one. It
That's
must
okay.
have snuck up towards the top. There
That's
were
okay.
a couple more that are coming in actually, so we have time
Okay.
to answer these. What does fortification of human milk include? Does it include bovine proteins? So Jenny or Angela, if you'd like to answer that one.
Let's see what.
Yeah, Jenny, can you see the question? I heard some of it.
Okay. What does? Oh,
okay,
go ahead.
Go ahead. I was just going to say I can repeat it again if you need me to. Okay. What does fortification of human milk include? Does it include bovine proteins?
So human milk fortification is going to include, lots of different components that, depending on the type of fortifier used, will depend if bovine is included in that. The fortifiers that we talked about today, specifically Prolacta, is the human milk derived fortification option that will not include bovine proteins, but the formula, or the bovine protein fortifiers, when you add to human milk, are going to then introduce that to the infant's diet. So, like I said, the Metolac is introducing or working to introduce an 100% liquid human milk based, which would, sounds more similar to the Prolacta option that won't introduce that bovine protein and will be 100% human milk based.
Okay, thank you for that. I see a question about recertification. Chris Kramer, if you'd like to email education@medela.com, I'd be happy to research that for you and get you an answer. I see that Nicole, okay, Nicole says, thank you. Does donor breast milk potentially have antibodies, including COVID antibodies?
Jenny, do you want to take it? Or
Well, no, I think I don't know that there's research to say that now. That would definitely be something, and I'm sure something that will be explored. But as far as I know, unless Angela, you know different, I don't think there's been any research to say one way or the other.
That's exactly what I was going to say, Jenny. I know of some facilities that are actively working, was previously focused on, does coronavirus appear in breast milk and the safety of breastfeeding early on in the pandemic. And really now that that research is out there, the shift to looking at antibodies within the milk of, like I said, previously infected mothers or recovered mothers, as well as donor human milk, and looking at the impacts post pasteurization if those antibodies are going to be present and offer some sort of protection.
And just to add to that, as more research on that topic is available, Medela will definitely have webinars such as this to announce that and let people know. One more quick question before we end. Are most NICUs now working hard to give babies mother's own milk?
I would say over, definitely in my tenure of working in the NICU, I remember back in the day, we didn't feed babies for a long time, 7 to 10 days sometimes if they were born, depending on how they were delivered and what went on initially. Now we know the importance of enteral nutrition earlier. And many times I feel physicians will write orders saying, once mother's own milk is available, start, such and such feed. So I definitely think now, with all the research that we do have, that more NICUs are driven more towards following research and establishing protocols to maximize getting mother's own milk to babies. So yes, that's a really good question.
Great. Thank you for that answer. Well, again, thank you everyone for joining us today. Angela and Jenny, thank you for presenting for us today. And I hope everyone has a great afternoon.
Okay. Thank you. Thank you all.